Okay, Dr. Abbott, take it away.
Welcome, everyone. I'm excited to host and moderate tonight's Sky Bifurcation Club webinar series on a very interesting topic of left main trifurcation disease, which we all know is quite an interesting lesion subset. And this is sponsored by Sky. Our agenda tonight, we have amazing speakers that are both from the US and international. We're going to start with a case on a step-by-step approach to the left main trifurcation stenting by Dr. Shiban, coming to us from Italy around midnight or 11 or midnight. This is going to be followed by a case of left main trifurcation in the setting of cardiogenic shock from Dr. Kumar from Atlanta, followed by the long-term clinical impact of angiographic complexity in left main trifurcation and PCI, and that is Dr. Kovacevic, who is actually coming to us from Belgrade, Serbia. So that is amazing. At midnight, thank you for staying awake. And we have an excellent panelist, Dr. Miriam Sawan, also from Emory Healthcare System. So really a packed agenda for tonight. I just want to thank Sky and the speakers for being here, and also thank Medtronic for providing an unrestricted educational grant for this activity on bifurcation, trifurcation webinar series. So without further ado, we're going to get to the first talk, and I'm going to hand it over to Dr. Shaban for his step-by-step talk. Thank you so much.
Thank you. Good evening to everybody. I'm really happy to share this case with you. The topic is very challenging. We are speaking about very complex procedures. I do not, can I move my slides? Okay. So in distal left main trifurcation, we might have different scenarios. That means we might have true trifurcation lesion or main vessel and two side branch disease, or single side branch disease, or only side branch diseases. That means one, two, or all three. And I'm not able to move my slides. And this is the how we can define, according to the Medina classification, the distribution of plaque in trifurcation disease. Go ahead, please. This was proposed by Kovacevic about 4 years back. That means to apply Medina classification to trifurcation with 4 digits from as was proposed by Medina, but adding the trifurcation side, that means the third side branch to the as 4 digit. This can help in selecting the procedure, I mean the strategy for the treatment of this challenging lesion. Ahead, please. And we know that we have different approach, that means from single stenting, 2 stents, or 3 stents, triple stent, that means to all branch sides. Please. But I think we should keep in mind the general consideration about distal left main trifurcation interventions to plan the procedure according to the clinical relevance of the side branch, to plaque distribution, branch angle, lesion length on each branch. And then from technical point of view, I think 7 or 8 French guiding catheters should be preferred. Triple wiring every time. Intravascular imaging should guide to select the appropriate procedure. And stenting, we should limit the number of stent as less as possible. and in order to avoid metal overlapping at the carina. Please go ahead. And if not complex anatomy, moderate calcification, and focal disease on 2 or all 3 side branches, that mean lesion length less than 10 millimeters, the default strategy and trifurcation should be provisional stenting. I just show schematically. Go ahead, please. This what can be to choose the stent, single stent into one branch, the most important or most diseased branch, and provisional stenting to the other 2 branches, as you can see in this scheme. Go ahead, please. Again, go ahead. This is one example of distal trifurcation with only single branch disease on main vessel, that means LAD, and mild stenosis on the side branch on ramus. And you can see that only following the provisional stenting, that means only crossover from left main to the most important branch, that means LAD, and fixing ramus with balloon or drug-coated balloon, and this will be the final result. If after POT there is no compromise on side branches, I think there is no need to go for crossing the stent and dilating the side branches. But if we have any compromise, then go ahead, please. Then you should go for a kissing balloon to both side branches, or singularly, or tripsy kissing. Go ahead, please. This is another example, the same very complex anatomy, but again here there is no disease on side branches, only single side branch, that means LAD was diseased, involved in the disease, and again only provisional stenting without touching any other side branch is sufficient to have very good result, as you can see here. Go ahead, please. Ahead. When 2-stent strategy is needed, tap or reverse tap can be the best choice. Recrossing, if needed, is easier because there is less metal across the 3rd side branch, which is not stented. You can see here in the scheme, again, we should choose the most important vessels, then starting with the reverse stenting of the side branch, that means reverse tap, and then completing with the 2nd stent to the other diseased vessel, crossing over from main vessel, that means from left main. Here I think that always we should have final POT, but we should be very carefully doing POT here, because we should not breach the arena with the carina with the POT balloon, because that might damage the protruding piece of the stent from the tap, if you are doing tap. If it is reverse tap, then that's no problem. The balloon can be placed at the carina as usually done in POT technique. Go ahead, please. Other techniques can be used, or strategies can be used if it depends on the anatomy and the angles between main vessel and side branches. DK crush can be done as well. Go ahead, please. If the angle is wide, you can see that the orifice of the ramus will not be will have only one layer of stent and be easily crossed. Again, go ahead. Also, DK mini colot strategy can be used as well if the side branch angles are wide. And you can see that go ahead, please. The fenestrating of the stent should be done for both branches before completing the colot stenting. Go ahead, please. And the true challenge is when you have true trifurcation, that means the whole three branches are involved, as well as the distal left main with long lesion on side branches. Then I think three stent techniques should be used should be the preferred one. Please go ahead. I'll go through this very complex patient, 85 years old male with severe and diffuse left main disease, as well as multi-vessel disease, as you can see here. Go ahead, please. You see several, all three branches are severely involved and diffusely diseased, and we have several tight stenosis also on main vessels. If PCI is a strategy, as in this patient, which was refused by surgery, then I think you should plan very carefully your procedure. Go ahead. The planning was to use seven guiding catheters, 7 French, 3 wires, pre-dilatation or lesion preparation, complex stenting for complex lesion, trying to keep it as simple as possible. And after pre-dilatation, we decide we'll decide how to proceed. No need for mechanical support. We just placed 5 French sheath on the contralateral axis in case will be needed during the procedure. We'll be ready to place it. Because blood pressure was quite high, and left ejection fraction was normal in this patient. Rota only if needed, undilatable lesion, but there was not so heavily calcified, was moderate calcification. We also will limit as much as possible the use of contrast. Intravascular imaging, I think in this case, cannot be used in the baseline, in baseline imaging. Go ahead, please, for the tight lesion. So we started with the wiring all three branches. Go ahead. Go ahead. Pre-dilatation from left main to all 3 branches. Go ahead, please. This was completed. Go ahead. Then we did reverse tap for Ramos. So stent in Ramos with very very small protrusion of the stent in left main, with simultaneous balloon going from crossover from left main to circumflex. Go ahead. Stent was placed in Ramos. Go ahead. Then balloon was inflating with kissing balloon inflation with the delivery system in Ramos, and the balloon in circumflex. Then another kissing versus with the balloon crossover from left main to LID. Go ahead, please. Then we stented from circumflex to left main. The intention was to do colot stenting from between left main, LAD, and circumflex. Go ahead. So stent was placed with very small protrusion in left main, as you can see. Go ahead. Then stent was, the first spot was done in the segment of the stent protruding in left main, one-to-one balloon in order to be sure that the position of the stent to left main was okay before fenestrating the stent. Go ahead. Then fenestrating the stent toward LAD. Go ahead. Fenestrating the and doing kissing balloon inflation with circumflex and LAD. Go ahead. And then we have this final shape of the stent, that means completely open toward LAD, ready to receive the second stent to complete culotte stenting. Go ahead, please. Before stenting left main, we just dilated and stented mid LAD where there was a tight stenosis mid LAD was treated. Go ahead. Then we are completing the culotte from left main to LAD through the open stent in open segment of the stent in distal left main. That means which was placed before as we have seen before. Go ahead. Then stent was deployed. Go ahead. Pot in LAD with the bigger balloon was 4.5 balloon. Go ahead. Then fenestrating the stent toward circumflex. Go ahead. And second kissing balloon inflation between main, left main, LAD, and circumflex. Go ahead. Then tripsy inflation, tripsy kissing, 3 balloons simultaneously. And then this was, go ahead. And final pot again after tripsy. And this was the final result. Go ahead. This is the final angio. I would say quite very good result. And this is the stent boost. You see that stent is expanded, no deformation of the stent. All 3 branches are covered with stent without any bulky overlapping of metal at the carina. Go ahead. This also was confirmed by IVUS, as you can see here. Good expansion, good apposition of the stent on on all 3 vessels. Go ahead. So in my message is that PCI and left main trifurcation is a challenging procedure. Consider incomplete or stage revascularization in patient with renal failure because it's almost long procedure and you should spare contrast injections. Plan your procedure strategy according to the lesion characteristics and patient conditions. No gold standard technique for left main trifurcation, but when possible, try to limit number of stents you are placing in these patients. And provisional stenting should be tried in many of these cases. I think that drug-coated balloon might make easier to minimize the use of stents to complete these complex and challenging procedures. Thank you very much for your attention.
Well, that was really amazing. One of the audience participants was interested to know what types of coronary wires you're using for this type of...
I was using hydrophilic wires, choice PT wires.
You did. And you don't worry about risk of perforation. Do you use them for wiring and then...
Actually, because of the tight lesions, and you see, if you look on the baseline angio, I mean, it was really very, very difficult to navigate through.
Yes.
And I think you should go very smoothly with these wires, but the coating, I mean, the hydrophilic coating helps very much in crossing this kind of lesions.
Thank you so much. And I know you're going to have to get off shortly, but, Dr.
No,
Swami.
I have at least half an hour, no problem.
Okay, good.
I do
Okay,
have a question, if that's okay. So you
Yeah.
prefer to wire with hydrophilic wires, which makes sense, especially when they're very tight lesions, but then you don't jail any hydrophilic wires, do you?
No, I did.
You do?
I am jailing. Yeah, I mean, if you are jailing that without, you do not have that much calcification. I think I mean, the hydrophilic wire will be coming back without any difficulty. I mean, at least in my experience, is this: if you have very severe calcified lesions, I think you might have some problems sometime, but not only with hydrophilic wire, also with non-hydrophilic wire will have the same.
I
Yeah.
see.
I
And then,
think, oh, go ahead.
oh, sorry. I was going to say, do you go upfront femoral or do you go radial? And when you do plan on stenting all three branches, like the case that you just showed us, do you go 8 French?
Actually, I'm using more in this complex subset of patients, and particularly in very challenging procedure like this, I'll go for femoral because much more comfortable, and you can use larger guiding catheter like 8 French also can be much more comfortable than 7 also in these cases.
Yeah, I was going to bring up two things like you said, Dr. Swan. I think there's sort of this historic concern about trapping the polymer wires because under like electron microscopy, you can have like lifting of the polymer coating, but I think it would be very unlikely to cause a clinical consequence, and they're also very unlikely to fracture or get trapped. So that's the positive side of using a polymer coated. So I think in this type of situation, it might be reasonable. And then the second thing is we use a lot of OLCATH, which is a sheathless radial guide, which is 7.5 French. If you want to try to stay radial, you can get close to the 8 French. I think that's one option, but certainly going with the ergonomic comfort in a long case where there's an amazing amount of steps. I mean, double the DK crush. I mean, this is an amazing amount of steps and an amazing amount of patience because it's very complex stent anatomy. So as you said, I'm extremely hopeful maybe DCBs can simplify some of this for us so we're not ending up with the 3 stents.
Yeah, I think it is very important to limit the overlapping metal at the carina. That means I will not use DK crush or double DK crush, for example, in these cases. Somebody will do double key crush, but I think it is not the case because you will have several layers of metal, layers of stents, and this can, of course, in this kind of procedure can make it more difficult to recross to side branches, and also might be, I mean, unfavorable outcome for, I mean, might predispose for stent thrombosis as well as for instant restenosis. So I think the main thing should be is not to have that much overlapping. If you are doing some overlapping, like in this case, I did kissing culotte stenting, but I fenestrate the stent for both branches before putting the second stent. So you will have only one layer in front of the ostium of the third side branch, which is not touched.
Yeah. One other question from the audience had to do with the stent platform. Certainly, the expansion capability of the side
Absolutely.
struts, and most of them are quite large, but do you have any recommendations? Do you just have these sort of expansion capabilities memorized? Do you keep a chart in the lab? Like these can be very complex when you go from smaller vessels to bigger vessels.
Yeah, sure. This is very important point. I think you should know the stent you are using. You should know the characteristics of the stent. Of course, you should choose the stent that have the capability to, you can enlarge it without deforming the stent. And we have more than one stent today going from 3.0 to 5 without any deformation of the stent. So I think this is very important point to keep in mind and to know to select your stent accordingly to the anatomy of the you are treating.
All right, thank you so much. Due to the late hour in Europe, we're going to move forward to our third talk first. Terrific. Our next speaker, Dr. Kovacevic, is going to be talking about the long-term impact of this angiographic complexity. So we'll have you go ahead and share your screen. Perfect and terrific.
Yes, just a second.
Yeah.
Can you see my slides?
Yes, excellent. Thank you.
Okay, thank you very much for the invitation. And so I'm interventional cardiologist from Serbia, as you could see. And I will speak about long-term clinical impact of angiographic complexity in left main trifurcation PCI. So first of all, I would start with one case. This is 63-year-old male patient with a STEMI. You can appreciate in this AP caudal, there is occlusion of the obtuse marginal branch, which was infarct-related artery. And also there is a left main trifurcation disease. You can appreciate this also in AP cranial view. So the question is, in this situation with the STEMI patient and occlusion of the obtuse marginal branch and left main trifurcation disease, how to proceed with these patients. Of course, due to the STEMI presentation, we decided to, of course, to do first infarct-related artery and to proceed with primary PCI, and we put one drug-eluting stent in obtuse marginal branch. However, how to approach and how to treat this left main trifurcation disease. First of all, we have to know some specificities about the left main trifurcation disease. So usually we have, not usually, but we have one proximal branch, a distal main branch, and we have two side branches. Unlike left main bifurcation disease, we have several different angles, and also the Finnett's law is different in comparison to left main bifurcation disease. Also, there is a ramus or high obtuse marginal branch. It can be also high diagonal branch, but if this branch originate less than 3 millimeters from the left main, then we can say this is left main trifurcation disease. So also Dr. Shaiban Imad, he already mentioned that there are different classification of left main trifurcations. The simplest one is Medina classification, when we have 4-digit number 0 or 1 to mark when there is a significant stenosis more than 50% in either main branch, proximal, distal, or side branches. Then there is also simple Shamas classification, similar to Stanford dissection, and there is letter A when there is involvement of both left main and side branches, and B when there is just involvement of side branches. There is also recently published the ABCD classification, maybe a bit different, and because the stenosis, they count just stenosis, but whether there is stenosis more than 70%. And we can mark with the uppercase letter if the vessel size is more or equal than 3.5, and lowercase letter if the vessel size is less than 3.5. In this, our particular case, we can say that this is Medina 1011. This is Shamas A, or a upper letter A, C, and small d. Of course, this is true left main trifurcation. We already heard that true left main trifurcation disease is if there is presence of significant stenosis is in either proximal or distal main branch and both side branches. This is some batch testing that I have done with Professor Francesco Burzotta in Rome when I was there for 1 year, bench testing with how we can treat left main trifurcation with simple crossover stenting, and also with crossover stenting, but with two-tap technique on side branches. In this particular case of a STEMI patient, 63-year-old patient, we took sheetless, as you already mentioned, sheetless guiding catheter, right radial approach, sheetless guiding catheter 7.5 French. We did predilatation of left main towards circumflex and predilatation of ramus with the 3.5, 2.5 balloon. Maybe nowadays this was the case we have done like maybe 2 years ago. Maybe I wouldn't go with the pre-dilatation of ramus. However, this was the result after pre-dilatation of left circumflex and ramus. Then we proceeded with the inverted provisional stenting from the left main toward left circumflex, and we implanted the 4022 millimeters stent. This was the result after stent implantation. Of course, maybe imaging would be it would be very nice and of course to perform imaging, some imaging technique, OCT, to understand whether there is a disease also in the ostium of LAD, because we all know that if there is disease in the distal left main, there should be some disease also in LAD, left circumflex, and ramus. However, we understood that we are going to do this first, like inverted provisional from left main to left circumflex, and then we will decide afterwards. Of course, this inverted provisional was followed by POT with the 50 balloon, 12 millimeters balloon, and this was the result after POT. Of course, we proceeded with the tracing balloon inflation, or triple balloon inflation, or tracing. Of course, we could do this with a two-step kissing between left circumflex and ramus, left circumflex and LAD. However, in this situation with the guiding catheter, sheetless guiding catheter 7.5, we could do tracing balloon inflation with balloons 4, 3, and 2.5. This was the result after tracing. As you can appreciate, the result was pretty good. Here in apicaudal view, there is some pinch in the ramus, but I think we think it wasn't significant, and this was the final result. What we can say about the left main trifurcation, what data we have so far? There were several studies, mainly registries, with the largest one that was MITO, Milan and New Tokyo registry, that included 84 patients. And as you can see, the MACE was different in those trials, from 9% in Taburino to 34% and Shamas, 33 Shaiban, the speaker, the colleague that was presented the previous case and talk. So we decided to proceed with to perform multi-center retrospective analysis or study. We included 4 centers. One of them was Gemelli Hospital, Rome. The second one was San Raffaele, Milan, and 2 hospitals, University Clinical Center from Belgrade in Serbia, and my hospital also from Novi Sad. We included 103 patients, and the primary endpoint was 3-year MACE. Just a second. 3-year MACE, all-cause death, MI, or target lesion revascularization. Can you? Okay, because something went wrong. Okay. Regarding the baseline angiographic and clinical characteristic, you can see that the average age was 67 years old, and diabetes was present in 37 patients. Stable coronary artery disease was present in 52%. So you can see that 34% of patients had non-ST elevated myocardial infarction, STEMI in 30% of patients. Also, 9% of patients had the cardiogenic presentation with a cardiogenic shock. Regarding the complexity of disease, mean syntax score was 28, and true left main trifurcation disease was present in 24% of patients. Regarding the procedural characteristics, you can also appreciate that provisional single stent was used in 77% of patients, and T or TEP technique was used in 17% of patients. Imaging technique also we used in 35% of patients, and which is not so small number regarding that 50% of patients was acute coronary patient with the inacute coronary setting. Regarding the angiographic and procedural success, it was pretty high. What we wanted to see whether there is how we can estimate angiographic complexity and its influence on MACE. So we tried to create a modified Medina trifurcation score. How we did that? First of all, we did we use a sum of Medina points. In this particular case, this is 3. For example, 1 from proximal main branch, 1 from ramus, 1 from for circumflex. Then we add also 1 point if there was a side branch disease in a length which was more than 5 millimeters. So in this particular case, it was 1. And then we get this modified Medina trifurcation score, which with a maximum of 6 points. And what we concluded regarding the predictors of 3-year MACE, we can see that 17% of patients experienced MACE, and this MACE was mainly driven by TLR. Regarding the predictor, there were several predictors by univariate regression analysis. You can see this was diabetes, true left main trifurcation, the number of deaths that we used in PCI and trifurcation disease, Medina 1111, and then modified Medina trifurcation score. However, when we did multivariate regression analysis, the only independent predictor of 3-year MACE was the modified Medina trifurcation score. So you can see that patient with the modified Medina trifurcation score, which was 6, they had 40% of 3-year MACE. Regarding the predictors of 3-year TLR, which was present in 11%, 12% of patients, the number of deaths in left main trifurcations was the independent predictor of TLR. And in conclusion, what we can say that PCI in patients with left main trifurcation is technically demanding and might require dedicated techniques, usually several wires, bigger guiding catheter, but also may result in high rates of angiographic and procedural success. It is associated with an acceptable MACE rate, at least in our retrospective analysis, which was mainly driven by TLR, and MACE also is independently predicted by baseline anatomic complexity assessed by the novel modified Medina trifurcation score. So thank you. I hope that you could hear me very well.
Yes, perfectly. That was amazing.
Okay.
And definitely you've been doing a lot of research in this area, and I would definitely have the viewers go to your 2021 circulation intervention review. It's very comprehensive. It's a very good place to get a lot of data up to 2021, at least for this topic.
Yes.
So thank you so much for publishing that. I think one of the viewers had a question about the pot. Assuming you finish with a pot, but like how many pots are you doing? How often are you potting? I mean, there's so many. What is the minimum? What is it? Do you have to finish with one? What is your sense on the pot?
Regarding the pot, I always do the pot. Anytime I do crossover stenting from the main branch towards side branch, I do pot all the time, always. I think 100% of POT pot when I do crossover stenting.
Perfect.
Yeah. Doesn't matter it's left main or non-left main bifurcation, but I systematically do the pot.
Yeah, it's so important. Some data suggests even more so than the kissing with the provisional. For sure, pot is where to go.
Yeah.
So, Dr. Swan, there's a question from the audience about DAPT. What's your feeling on DAPT with these trifurcation interventions? Does it depend on the number of stents, on the indication? How are you doing it?
Yeah, that's actually a really tough question. I don't think, the TLR, as you just showed, is higher, and you would, expect it to be higher because especially if you're going to stent all 3, and so you have more metal there, and especially if it's the left main. So I would err towards putting them on DAPT for a longer period of time. Obviously, if it's a STEMI or an NSTEMI, by default, you're going to have to keep them on DAPT for a year. If it's stable chronic disease, then I would try to put them on DAPT for at least a year. And if they're still stable, maybe at a 1 year standpoint, but that's just, I don't think there's like a standard practice as to what exactly to do and how long to keep them on DAPT.
I think it's a good point to bring up because the field is going shorter and shorter, and potent P2Y12 only, and certainly in acute coronary syndromes using a more potent agent. And that it's such a debate. But as we go to trials like Neo Mindset and all these trials where we're dropping aspirin very quickly, I think when you have multiple stents like a trifurcation, it might be the one situation where you shy away from extremely short DAPT. I don't know if other speakers on the webinar have an opinion.
Yeah, I would think that would be a scenario where I would probably try and keep the patient on DAPT for at least a year. And if it's if it's an ACS setting, pardon me, that would be almost mandatory. Now, after a year, that's where I think the fun begins, because at that point, it is pretty much pick your own poison. There's people who do drop the aspirin, drop the P2Y12, downgrade to a low potency P2Y12. I think the answer is still out there, or a lower dose of high potency P2Y12. So there's various different options at that point. Obviously, it has to be balanced against bleeding risk in that patient as well. So I think it's a very individualized decision, and it's not a decision where one size is going to fit everybody.
Yeah, but except for the highest risk bleeding risk patients, I think don't short.
I did have one question before we move to the second talk, if that's okay. I wanted to ask Dr. Kovacic, do you have a stent preference? Do you lean towards, if you do decide to go up front by stenting all 3 branches, is there a stent that you prefer to use? Namely, do you try to use a stent with ultra thin struts and move away from stents who are known to have more thicker struts in these situations?
Usually I would try to avoid triple stents, in left main trifurcation, especially nowadays that we can use DCB, like drug coating balloons. So I would go for DCB, maybe rather than to put like 3 stents in left main trifurcation. However, I have several stents that maybe 3 stents platform that I would use, not extra thin strut, but maybe the stent that would provide good side opening for side branch. So it could be Resolute Onyx or expansion, Science, Nagomi, like but I think that the first one would my preferable stent.
Okay.
So just the stent expansion, if there is, because it's always going to be a huge discrepancy between the proximal main branch or left main and usually side branch. So the stent expansion would be the first criteria for stent platform if I choose one over the other. Okay. Expansion of the stent and the opening for side branch.
Okay.
Before the last question from the audience, if you don't mind, before we move on, it was specific to your study when you looked at independent predictors of the MACE in your study. I saw you said number of stents. Was there anything about the diameter of the side branches?
No. That's why we tried and we create this modified Medina trifurcation score. Nothing about the size of the side branch. But the length, maybe we should use the length of the disease 10 millimeters as it was used in left main bifurcation disease. However, we have 2 side branches, and then that's why we use like a cutoff of 5 millimeters. But we could do another research to understand more.
Yeah, maybe if you get a bigger sample size.
Yes, this is small sample. Yes.
Actually, I think that the length of lesion of side branch is very important. As you see, as you show by the score, only side branch length. So I think that's the main thing to do.
Yes. Yeah, agree.
Increasing the MACE. And the second point that You mentioned our study in 2000 was published in 2009. At that time, we thought that drug coating stent was resolving every problem, and we were using
Yes,
2, 3 stents in every trifurcation.
yes,
That is was we had high MACE at
high
that time.
rate.
Yeah.
Yes, I agree. Yes, yes, yes. It was long time ago.
Thanks
Yeah.
for putting that out there for us. So we're short on time. Thank you so much for your participation from
Thank you very
OUS
much.
in the
I
late
have to
hour.
leave because I
Yes,
have to
we'll
wake
have
up.
you
Thank you.
go.
Thank you
Yes,
very much.
yes, get some
Thank you.
sleep.
Thank you.
Goodbye.
Our
Goodbye.
final
Thank you.
talk is Dr. Kumar is going to take us through what do we do when somebody is unstable and we're dealing with the trifurcation. There's some more questions in the queue. We'll get to them hopefully about DCBs, but we'll try to finish up if we can with those questions. So, all right, thank you so much.
Hello, are you all able to hear me?
Yes, perfect.
Perfect. Okay, so this is left main trifurcation in AMI cardiogenic shock. I have no disclosures pertaining to this talk. So, this reminds me of actually one of the older EBC position papers that basically had the same story. One day, Alice came to a fork in the road and saw a Cheshire cat in a tree. "Which road do I take?" she asked. "Where do you want to go?" was his response. "I don't know," Alice answered. "Then it doesn't matter." Well, we don't want to be like Alice in this scenario. We want to know where we are going. So we want to be more like Stephen Covey, who says, begin with the end in mind with in his 7 Habits of Successful People. So that's where I want to start with. Very brief overview here. In humans, actually, the left main trifurcation is the most common anatomic variation in about 10 to 15%. Management tends to be usually surgical. PCI has become more common given better techniques, better technology. Stent sizing is complicated. We have discussed the Finette's rule, the modified Finette's rule, and with the different equation that not everybody might be familiar with. I feel that in the contemporary era, imaging is essential. We may have difficulty doing post-imaging of some of the side branches because of catching on stents. Either two-step kissing or tracing is probably mandatory. POT is also just as important. But the question remains, can we manage all of this in an unstable patient? And that's what we're going to talk about here. So this is a 69-year-old male with chest pain for 2 days, classic late presentation. I was called from an ER physician at a different hospital, and I was told that his blood pressure was 84/60, heart rate of 110, with cold extremities, JVD to the angle of the mid-neck, and normal heart sounds. He was then transferred to our center. As these things sometimes go, it took about 2 hours for this patient to get here. By then, we are getting lab results from the other hospital. So we found that the lactate was 5.1. So we brought the patient directly to the cath lab. This was the ECG that he came with from the other center. And, there's no mistaking what's going on here. The Q waves are indicating that some of this is late in the process, but he's still having ongoing chest pain and he's in cardiogenic shock. We put a quick echo probe on his chest, and what we found was unfortunately not very pleasurable. As you can see, there is extensive akinesis of the anterior wall as well as the apex. Fortunately, no thrombus. So we decided to go up with a guide and see what we can do. We came up right radial, and I wanted to show you that picture in the beginning because this case is going to be in real time. We're building the plane as we're flying it. So, I got up there with the EBU 3.5. I couldn't get selectively engaged. So I said, okay, let me come up with the EBU 3.75. That's the second image. And you can see that, the left main looks terrible in all of those images. At that point, I'm also getting his blood pressure numbers, which look terrible. And I say, okay, you know what? We are not going to be able to approach this. Let's quickly get mechanical circulatory support. And you can see I've gone in with the Impella CP that has been placed. EDP was 31 millimeters mercury. And this is the guide EBU 375 using the ship technique from the groin now. And the LAD was rapidly wired with a run-through wire. And you can see that wire going down that LAD there. And we elected to put pilot 50 into this. I don't know whether you want to call it a Ramus or a OM1. In any case, it is definitely less than 3 millimeters from that bifurcation. So this is a true trifurcation case that we're talking about here. And I was forced to deal with the SCAI costume since it was severely diseased. I decided to go ahead and position a stent there and extend that into the Ramus since it looked like a bigger vessel, and stented that with a 275 by 30 Onyx Frontier. This is the IVUS that I performed just prior to deploying that stent into the LAD. And you can see the wire coming out from the circ, and you can see the left main is severely diseased. There is a small amount of thrombus in that distal left main as well. So at that point, now that the circ is controlled, I decided to do a nano crush of that circ stent. And that's what I'm doing here with the U4O balloon, and with a 4O balloon there, and following that, quickly placing a 5O by 26 Onyx Frontier in the left main into LAD. Following that, I'm opening up the stent struts with a Euphora, and then following that very quickly by a kissing balloon in the LAD and the circ. And all these balloon inflations are very rapid. They're like 10-second inflations, literally. At that point, the proximal left main and circ are under control, but of course the LAD still looks terrible. So I decided, okay, we have to address this LAD. We go down the LAD with the Onyx Frontier, stent that in the distal LAD, and a slightly larger stent in the mid LAD. So following that, it looks pretty decent on that final image right here. There is still some slow flow distally. We needed to post dilate one of the stents. We did that, and then we had some no reflow. We had to go down with Suzuki microcatheter and give some IC epinephrine. If you look on the IVUS on the right, you can see we did not get perfect overlap between two of the LAD stents. There is just one strut where we don't quite have an overlap there, but we decided that we're going to leave that at that point. And if you look, you're going to see that there, right there. That's the one segment where we don't quite have an overlap, but it's relatively disease-free. We're going to go back in and post-dilate that stent strut and expand that. And that's what caused the no reflow in the LAD, which we then had to fix with epinephrine. At this point, his blood pressures had been, he had to have been, we couldn't give nitro or nipride or any of the other agents safely at this point, since, he was just, even with the impeller, he was right around a map of 60, 65. So I'm going to go back one slide and show you the final image of the left system. And that actually looks pretty good. There is disease in the OMs that are further down, but we decided to leave that for another day. The LAD looked pretty decent with a reasonable flow. There is some bridging distally. You see that on the IVUS as well. We then decided to take a picture of the right coronary artery for those of you purists, and it looks okay. So the outcome ended up being that the patient was clinically better. His lactate dropped to about 1.8 within 4 hours. Pressors were weaned about 6 to 8 hours later. We were able to explant the impeller CP the next day, and the patient was discharged 3 days later, but his EF remained low on GDMT, and he required ICD implantation 6 months after. We are now about a year after this procedure. There's a couple of points that I wanted to bring up that I felt were salient here, which is, we should identify our goals in these difficult cases. We need to decide where you want to go. There's no point being academic about, okay, I have to do trissing, I have to do double kissing. I think we need to be flexible and think, okay, if I can save 2 branches, I'll go with it, simplify the solution. I think, especially in AMI cardiogenic shock, early initiation of MCS is essential, especially in the light of the danger shock trial. It's important to work quickly and avoid prolonged balloon inflations, get help. I'd like to thank my colleague and our friend, Dr. Tanvir Rab, who's been involved with the SCAI Bifurcation Club for a long time. and I had him helping me for this case. Imaging here is critical. Data is somewhat limited in this space with, as you can see, we looked at some of the data earlier, but I think that's where we're at with these tough cases. Thank you.
Thanks. That's amazingly difficult, and thanks for sharing it. We have a couple of minutes left. Of course, I think if you showed this case to 3 interventionalists, you'd get 3 separate opinions. And one of the audience members was asking what triggered the ramus stent first, because I think most people would have just had a protection wire and done the LAD left main and only done bailout. Like, what was something happening with the flow there? Were you worried about the angle there? What was the impetus for that?
We were very concerned about the angle there, and it was severely diseased at the ostium. I actually attempted to IVUS it in the beginning, and the IVUS would not even cross through that ramus, or high OM. So that's why I felt that there was actually, technically, it is a high OM because there is a common circ ostium. So I felt that if we messed up something in that, we're likely to lose the whole circ. My other impression was, given the fact that this was a late presenting STEMI, chances are that LAD territory may be gone, and the circ territory may be his only living territory in addition to the right coronary territory. So if we lose the circ, we have a chance of losing a lot. So that was my calculation in trying to salvage the circ.
Yeah. No, that's what's great about interventional cardiology. As long as you have a justification, it seems reasonable. I think you could, again, I think multiple people would have approached this a different way, but I think securing the vessels with a wire is certainly advisable, and then you can decide what the priority is. There's some questions in the chat that were from some of the doctors from Europe, and they had to jump off. So I would encourage people to pull up their science that's published, because some of these series are small, so I don't want to get hung up on the details of some of those studies. And same thing with the P2Y12, because we just don't have that data. But Dr. Sawan, I mean, do you want to give us some take-home messages from these talks? Do you want to, I mean,
sure.
It's been amazing.
It is.
Amazing.
All the cases are
array here.
amazing,
Yeah.
for sure. I mean, it's never easy. Left main bifurcations isn't easy, so left main trifurcations are definitely not easy. But what I think the take-home messages are, firstly, try to make it simple. Simple is actually elegant, and go in with a plan in mind. Which vessels are the ones that you cannot lose, and they're very important. And usually that is the ones that are supplying the most territory, and which one you're not going to be upset if you lose to some extent. So if you can get away with only 2 stent strategy, that's better. And then you can use DCB for the remaining. So, and then the other thing that Dr. Kumar also mentioned, which is really important. So if the patient's unstable, really, really avoid prolonged balloon inflations. At that point, especially when the patient's unstable, a lot of times it's soft plaque that you're dealing with and they're unstable. So take a minute, make sure you have the right MCS. Usually it's going to be an Impella. And then address the lesion. And in that point, definitely do not use DCBs, because you can't keep the DCB up in a patient who's unstable for 2 minutes, even if you have an Impella. It's just a bad idea. So at that point, try to simplify things and just go in and out really as quickly as you can, and then to get the patient out of cardiogenic shock. That would be the big take-home messages I would give. And then if you want and you have the time, and if you do think that you're going to end up doing a trifurcation, which is less favorable now in the days of the DCB, then maybe femoral and an 8 French. I think going in with a really set plan and with the right equipment, the right guide, it just makes everything much simpler. And planning is important.
Thank you so much. Great. I am just typing some responses to the remaining questions in there. Hopefully, we were able to answer all of your questions. For those of you who came on, we had a wonderful wide audience. I really want to thank our panelists here, Dr. Swan, our speakers, Dr. Kumar, and all our European colleagues from Italy and Serbia who had to, go to bed, and the SCAI staff and Medtronic. It's been a wonderful meeting, and hopefully you can view the presentations later. Thank you so much. Have a great evening,
Thanks for
everyone.
having me.